Thank you for coming in person. This is actually the first Global Health Grand Round that we are having where our visiting speaker is actually live here. So we're delighted about that. I am delighted to introduce our speaker, Dr. Caline Mattar. Caline is an associate professor of medicine at the Washington University in St. Louis. She completed her medical studies at the American University in Beirut, Lebanon, where she practiced medicine prior to moving to US to do her residency and then after infectious disease fellowship. Her academic research focuses on dissemination and implementation of infection prevention and antimicrobial resistance interventions in resource-limited settings. She has served on multiple national and international expert groups and advisors, including expert advisory to WHO on antimicrobial resistance and infection prevention. She chairs also the expert advisory group of the Global Antimicrobial Resistance Research and Development Hub in Berlin. She currently serves also on the board of directors for REACT Action on antimicrobial resistance in Africa. At a national level, she serves as a member of the Global Health Committee in Infectious Disease Society of America. That's where I know her, actually. We served together on that committee. At Washington University, she directs various programs for global health and health equity education. She's the director of the Global Health Scholars Pathway in Internal Medicine and serves as the director of Global Health Education and Partnerships. She co-founded the Women in Global Health Midwest chapter in 2018. Caline is a rising star and considered a leader in the implementation science of antimicrobial resistance and stewardship when you think about low and middle income countries. By the way, in addition, she is an associate program director for their fellowship program, also for the infectious disease fellowship program. So her talk today is titled as Global Antimicrobial Resistance, the Good, the Bad, and the Ugly. And Caline, I leave the floor to you.
Thank you so much for this very kind introduction. And it's an absolute pleasure to be back at UW among friends and colleagues. So thank you again for the invitation. So I have no relevant financial disclosures, and all the other colleagues involved also do not have any. So over the next 50 minutes or so, I'm going to be talking to you about some of the good, but a lot about the bad and the ugly in global antimicrobial resistance. I'm repeating myself, but I have no financial disclosures. So at the end of my talk, I hope that you will be able to describe the burden of antimicrobial resistance, or AMR, in the US and globally, define the major drivers of AMR, outline some resistant challenges that are specific to low and middle income countries that I'm going to be calling LMICs just for short, and then identify priority interventions to address AMR globally. And just to kick us off about the global burden of AMR, a little historical piece, well, not too long ago, in 2014, the UK government commissioned an economist, of course, Lord Jim O'Neill, because why not? In the UK, everybody's a lord. So to review or to do a review of antimicrobial resistance at every different level. And in that review that was quoted very widely, it was estimated that by 2050, 10 million people, so 10 million lives will be at risk from antimicrobial resistance, but also $100 trillion of economic productivity will be lost. But a lot of the global health experts thought that this is really a significant underestimate. So we still kept with those numbers up until, again, the UK government commissioned or was the main funder of the GRAM project, which is a collaboration between Oxford University as well as the Institute for Health Metrics and Evaluation out of the University of Washington. You probably know them as the main producers of the sort of a Bible of numbers in global health, which is the Global Burden of Disease study. And out of that was born the Global Burden of AMR, which indicated that in 2019, an estimated close to 5 million deaths was associated with bacterial AMR, and really 1.27 million deaths directly linked to antimicrobial resistance. The highest burden was in sub-Saharan Africa at 27 deaths per 100,000, and the lowest was in Australasia at 6.5 deaths per 100,000. This is significantly more robust data. The initial data from the Jim O'Neill review was really just mainly modeling. This one took into account systematic reviews, hospital level data, surveillance data from the national, publicly available, private sector, etc. While far from perfect, it still is a significantly better estimate. Lower respiratory infections constituted greater than 1.5 million deaths, and the big culprits were E. coli, Staph aureus, Kleb pneumo, Strep pneumo, Pseudomonas, but also Acinetobacter, which is, we think, is not a major issue for us, but we're going to see something a little different. MRSA was the cause of greater than 100,000 deaths. Now we're going to look at a couple of maps. I'm just going to go through the colors because we're going to use the same ones for the next 3 slides. Pretty much purple is less than 5%, so purple is good. And then as we go to lighter shades of blue and then green, this is an increase of percentage of resistance until we get to the orange and red colors, which are actually significantly higher percentage of resistance. So when we're looking at carbapenem-resistant Klebsiella pneumoniae, we see that the US and North America is doing pretty good. Even sub-Saharan Africa is. But if we look at India, Russia, Egypt, we have anywhere between 60% to 80% CREs, carbapenem resistance. And as you can imagine, carbapenems are meant to be last resort antibiotics. So there is a classification from the World Health Organization called AWARE, which is access, reserve, and then carbapenems are on the reserve front. So they are resistant, so 60 to 80% resistance to carbapenems. And then when we move to Acinetobacter, which is an already really mean bug because it's intrinsically resistant to a lot of classes of antibiotics. When we look at carbapenem resistance, this is when things are really ugly in really major parts of the world. So Latin America, Asia, the Middle East, we have in most of these places greater than 80% of carbapenem resistance. And you're telling me, but okay, so what? I mean, it's resistant to carbapenem, but why don't we use something else? The problem with Acinetobacter, as I mentioned, is intrinsic resistance. So if we can't use carbapenem, we're left with a couple of classes, including polymyxins, so colistin, which is, as you know, is a very toxic antibiotic, and some of the tetracyclines, such as minocycline, tigecycline, and those are not always readily available, and they are not first-line agents. And then when we look at MRSA, this is yet another different story. And you'll see that North America, and particularly the US and Mexico, we are in orange. So we're not in purple, we're not in blue or in green. We're not doing very, very well. So we have really anywhere between 50 to 60 and 70% resistance. You have countries such as Mongolia, and the Middle East with greater than 80% methicillin resistance. Now I'm just going to ask you for your thoughts and if you agree or disagree with this statement. So to join the poll, you can go to pollf.com and then Caline Mattar 065, or you can text that as well. The instructions are up there. Basically, I just would like to know your honest opinion. This is absolutely anonymous. I won't know who you are. Some of you are thinking, she is very dramatic. I mean, it's really not such a big problem. Others are thinking, well, maybe it is. So what do you think? And I'm asking you about your thoughts about AMR in the United States. Very well. Oh. Well, I think many of you are indulging me, so thank you so much for that, with a strong agreement. And over the next couple of slides, I'm going to try to prove you right if you indulge me. If you didn't, all right. So for the US burden, we actually have reasonably good data from the CDC. Not perfect, again, but reasonably good data. The CDC 2019 antimicrobial resistance report mentions 2.8 million resistant infections every year and 35,000 deaths. It is an underestimate significantly. And the reason for that is I am sure everybody knows here that everyone in the US dies from cardiopulmonary arrest, period. So we are often missing the mark on really what caused the cardiopulmonary arrest. If it is sepsis, if it is an infection, we're absolutely missing the mark on death certificates, on reporting resistance, if that has contributed. While we have surveillance data, it's not always very easy to match those at a country level. Well, but if we do believe those numbers, we have 3 million C. diff infections per year, that was in 2019, with 48,000 deaths. So you see the problem? So C. diff results from either overuse, misuse of antibiotics, and or hospital-acquired infections. So we have more death from C. diff than from antimicrobial resistance. That's not good. Burden is likely much higher, as we discussed, and the problem is we really lost a lot of progress during the pandemic. We had an increase in resistant infections. Many of those are healthcare associated. The problem was we significantly increased our antibiotic use. Earlier on during the pandemic, when people were very sick in the ICUs, on ventilators, etc., and in a sepsis, a shock-like picture, that was justified. We had no clue, is it COVID, is it a bacteria, etc. But what we really got to know very quickly is that in the first 7 days, it is COVID, and it's very unlikely to be a superimposed bacterial infection. And yet, so many of us continue to use broad-spectrum antibiotics in those critically ill patients. In addition to that, we also shifted many of our staff and folks who work on surveillance and prevention of hospital-acquired infections truly towards COVID completely, which also really made the data less robust. Also, reporting requirements became a little more lax, evidently because we were very worried about our COVID numbers. So at least 15% increase in hospital-acquired infections and death from 2019 to 2021. Now, talking about the NHSN data, so the National Healthcare Safety Network, which is a gem for ID docs, maybe, sometimes a source of angst and hate for our infection prevention colleagues. I know colleagues from crit care and the ICU absolutely hate NHSN, and every time we come with some reports on central line associated bloodstream infections, catheter-associated UTIs, et cetera, et cetera. But this is a system that is not exactly perfect, but it's actually quite good because it has definitions that we all use to really identify those hospital-acquired infections. We saw a significant increase in every single one of those HAIs. I mentioned that I'm going to be talking about some good. Here you go. This is the good. Decrease in C. diff infections during the pandemic. We realized that it's great to wash our hands. And when we do that, we decrease C. diff infections. We increase PPE use because people were scared of COVID. There were no big adventurous folks walking into COVID rooms, at least initially, without proper PPE, or the PPE that you would use to prevent C. diff infection. And then we enhanced our cleaning practices. Now, enough of the good. I don't want you all to be very optimistic anymore. Go back to the bad and the ugly. 35% increase in carbapenem-resistant Acinetobacter and carbapenem-resistant Enterobacteriaceae, and 32% increase in ESBL. And then another measure of how well we're doing with antimicrobial resistance, but specifically with antibiotic prescriptions. So this is a map for community antibiotic prescriptions per 1,000 population by state from 2019. The darker the color, the worse it is. So the darker the color, the dark red is 920 to 1,193. And you will see who is on the naughty list. So the naughty list is pretty much the South, most of the South, Nebraska. Wisconsin is actually doing pretty well. So Missouri, I don't know. If I were Santa, between nice and naughty, I would not sure if they're gonna get a Christmas present. But we are not very good at prescribing outpatient antibiotics. The biggest majority of those antibiotics are for upper respiratory infections, and we all know how few are the URIs that really require antibiotics and antibacterials, and cystitis, and we know how often we treat asymptomatic bacteriuria when it does not really need to be treated. So switching gears a little bit to the global aspect, before I continue kind of some of that discussion, I do want to mention that this AMR has been in the political, global health political scene where a lot of the investment happens really very strongly since 2015, where the Global Action Plan on Antimicrobial Resistance was adopted at the World Health Assembly, so at the World Health Organization, that outlined 5 key priority areas. And they were a really great start. And since then, those have been built upon significantly. And this is the basis of a lot of the work that is happening globally on AMR. After that, that political momentum continued so much that we were able to take AMR to the UN high-level meeting, so in New York, to the UN General Assembly in 2016. It came up with this very long political resolution that I invite you all to take a look at because it's actually interesting. There weren't really very firm commitments, and there was no legally binding anything in that document, so it just stays as a really nice, important document, but not everything followed suit. And then G7 communiques on AMR, which has been happening almost on a yearly basis. And G7 are the highest income countries, maybe the most politically present, if you will. But remember that those are 7 countries, and they're depending on what you're counting, countries, territories, member states. We have over 200 that if we don't engage everybody, we're really not gonna make enough progress. The last document that I want to mention is actually fresh off the press from the OECD countries, so the Organization for Economic Cooperation and Development. Again, those high-income countries that come together from all over the world to talk about what they think are a priority. And this is talking about needing a One Health approach to tackle AMR and talking about the different progress in various parts of the world. And as you can imagine, significant progress is happening, it's just really not everywhere. When we're talking about the drivers of AMR, we are here, in a human hospital, but AMR is a lot more complex. It's not only an issue of human health, but it certainly starts in humans, or it certainly affects the lives of humans significantly and the things that are important to us as a species. So drivers of AMR: misuse, overuse of antimicrobials, poor access to antibiotics. And you're going to say, well, this is counterintuitive. It's actually not. And I'm going to tell you a little bit how. Quality antibiotics. So there's a lot of substandard, falsified, counterfeit antibiotics that are sold in many parts of the world. And you can imagine those could be active, could not have enough of the active ingredient, et cetera, et cetera. Access to vaccines, access to diagnostics, lack of awareness and knowledge, and that's not it's a global issue. Population movement, conflict, etc. When we're talking about animals specifically, we see exactly the same issue. The problem with animals, and particularly with farming, is that in many parts of the world, including the US, we use antibiotics for growth promotion and for prevention of diseases. So animals are in absolutely horrendous conditions. And instead of treating the animals in a more humane way, What we do is we cram them all together and we give them antibiotics to prevent infection and death. There's also in parts of the world access to quality antibiotics for animals as well. We don't have a lot of diagnostics. We don't have vaccines for animals. And then again, lack of awareness and knowledge. Food and feed, you'd be surprised, but there are certain crops that are actually sprayed with antibiotics for prevention of disease, as well as also increased growth. It has happened in Florida here with citrus trees. So it's not really across the ocean. It happens in the United States as well, where we think there is a lot more regulation. The environment in hospital systems, pharmaceutical manufacturers, they dump their waste in the soil that reaches water. And then you have a significant increase in resistant organisms that are kind of living all around us. By the way, we talk about animals and I talked about farming, but that also applies to fish farming, especially salmon farming, et cetera, et cetera. And then there is also the water sanitation and hygiene aspect that really is relevant to every single problem around the world, but the lack of access to clean water, to proper sanitation, and that is both in the community, but also within the healthcare systems. So how do we, kind of really quantify each and every one of these? The one thing that I want to mention before we quantify things is that what is the impact of antimicrobial resistance? All of us in this room, we're mainly concerned by health of our patients. But one thing that is important to remember is that policymakers and all of us in some ways need to be concerned about the economic impact. So increased length of stay, increase not just mortality, morbidity, but also cost of care and treatment, loss of production, loss of kind of economic production. So those people with resistant infections, prolonged hospitalizations are not working, are not producing. And then also linkages with climate change and the environment as well. So when we're looking at those different contributions and we're thinking, well, how does all of these factors, how does it really impact my patient and human health and human AMR? Well, somebody actually looked at that. And this is a systematic review that looked at 527 studies to look at the contributions of each of these drivers of AMR for resistance in human health. And what they basically found that prior antibiotic exposure, invasive procedures, but also pre-existing conditions increases your odds ratio of developing an antibiotic-resistant infections by 2 to 4. So these would be the biggest contributors. Not to say that the others are not important, but these would be the things to focus on. So with that, overuse and misuse, big and biggest drivers of AMR in human health. So I certainly wish that at WashU, we in ID had the power to approve meropenem or not approve, and that it was harder than to get meropenem than to get an AR-15 in Texas. It really isn't, unfortunately. We actually use a handshake stewardship model in our hospital, and we only restrict really newer generations of antibiotics. But, just this meme down here, this is exactly what ID docs and stewardship folks really think about. We really would love those folks who discontinue antibiotics, and vancomycin, just in case, not a good idea. This is all coming from ID Stewardship, which is who is an ID clinical pharmacist. Fantastic. I invite you to follow his page on Instagram because it's a lot of fun kind of teaching moments for treatment of infections and stewardship. All of this is really not that simple, particularly in the context of LMICs. We have very specific challenges that I kind of touched on, but it's really important to delineate each and every one of them separately. The first one is evidently water sanitation and hygiene. As you can imagine, if you don't have kind of clean running water, it's very hard for you to function in a hospital and be able to prevent hospital-acquired infections and transmission of disease. There's not a lot in terms of infection control programs and resources in a formalized way like what we have over here. We do lack comprehensive surveillance data. What that entails, I mean, if you go look right now on the WHO page, there is a global surveillance network called GLASS, and that was definitely an improvement from nothing. But the problem is that countries report isolates, mostly from tertiary care academic centers in the capital, and we really have no idea what happens 2,000 kilometers into the rural part of a large country, for example. And folks from the country also understand the challenges with that surveillance data, and they can't really use it for a good reason. There's an issue of access to antibiotics and diagnostics, and you're telling me, but it's a good thing if they can't access antibiotics, there's no misuse. Well, the problem is they can't access earlier generations, very cheap antibiotics that are either completely unavailable or very poor quality, because there is no incentive to pharmaceutical companies to continue manufacturing those. They don't have access to newer antibiotics, and they're stuck often with using certain antibiotic classes, such as we see very often third generation cephalosporins, so ceftriaxone, augmentin, etc., and really not a lot on the two other ends of the spectrum. And you can see how this is not ideal for treatment of every single infectious condition. There's a lack of formal stewardship programs. We're going to talk about that. There's over-the-counter antibiotic sales. And if you tell me, but why don't we just ban them? Well, the WHO has started to try to get countries to ban over-the-counter antibiotic sales. But the story is a lot more complicated, because there are countries where you have people who can't access a single qualified healthcare worker. We have 1 billion people globally who will never see a single health worker in their whole lifespan. So you can imagine that for many people, those over-the-counter kind of medicine shopkeepers are their only access to healthcare. So if you cut that off, you're going to see people dying from lack of access to antibiotics. Those are people who are not trained and who are mainly doing or selling antibiotics and other medications for profit. So how do you align those priorities? Unregulated food production, including livestock and agriculture. It's not only an issue of LMICs, it happens everywhere, and I briefly touched on the US. And unregulated pharmaceutical manufacturing and waste disposal, and lack of awareness in the public. And that is something that is also true for here in many other countries. The WHO actually, in 2018, when we were at that time discussing truly what is stewardship and how do we affect stewardship and make effective sustainable change, they brought up the antimicrobial stewardship continuum. And this is not talking about the stewardship program that will come and tell you to stop meropenem in the hospital. This is a kind of longitudinal addressing antibiotic use from A to Z, if you will. So it starts off with research and development, so R&D to develop a new antibiotic. And then that antibiotic doesn't just kind of pop up and we can start using it. It has to go through the regulatory process. So think about FDA approval in the US. There's an equivalent in every single country around the world. The Europeans do it a little bit better because they do it as a region. So there's the European Medicines Agency, but Japan, China, India, et cetera, they have their own. So imagine getting that drug to be available and approved in every country around the world. Then we'll get to procurement and supply. So you have to import the drug, or you have to manufacture it locally at a large enough quantity and make it available in a longitudinal kind of sustainable fashion. Then you have to distribute it to various parts of the country, which depends on wholesalers, sometimes on the equivalent of a national stockpile for antibiotics. We don't do that for everything in the US, but we do it, for example, for Cipro, for thinking about bioterrorism agents, etc. But there are countries that do it for infections in general and for meds that they would need otherwise. And then after that, you have the prescribing aspect, which includes access to the proper diagnostics that you need. And then you have the dispensing, which depends on pharmacies, on shops, but often on insurance. I think I wouldn't sound foreign at all if I told you how many times you've had to call an insurance company because they refuse to cover, let's say, Cefdinir, and they offer you to use Keflex instead. And you're like, but I am not going to use Keflex because this is not the right drug. Well, you can use IV ceftriaxone. So this is also another step that really prevents us often from being able to make the right decision for our patients. And then if we have all of these we can reach responsible use. So it's not a simple discussion, really not globally, and certainly not even at one country level. So additional challenges for low and middle income countries. I'm going to briefly talk about this report that is actually coming out of the Global AMR Research and Development Hub that is based in Berlin, for which I chaired the expert group, because this was a first kind of one-of-a-kind study, because there's a lot out there in terms of incentives for new antibiotics, and I'm going to touch on that briefly. But what we aim to do is to try to look at where do we really need those antibiotics, and what kind of numbers and what kind of market potential are we looking at for these pharmaceutical companies that are going to research and hopefully develop these antibiotics. What we figured out is, after looking and modeling data from 13 countries from all around the world, a couple of things showed up. We modeled those numbers specifically for two conditions, so resistant gram-negative bloodstream infections and pneumonias, and also for the need for a diagnostic that would differentiate between a bacterial and a viral infection. And what did we find? The greatest unmet need for new antibiotics and diagnostics is in low and middle income countries. And I hope it doesn't come as a surprise to you after I showed you all of these resistant maps. Our models also showed that by 2040, 8.3 million people will suffer from MDR, gram-negative bloodstream infection or pneumonia. The highest burden is in low income and low middle income, so not upper middle income countries. And all of these are evidently outside of innovator countries. They're completely outside the countries with very strong pharma presence that would otherwise develop these innovations. And the one thing, as an FYI public service announcement, what I learned, and it came as a complete surprise, is that big pharma really only looks at the US market when they're quantifying their market potential, and not so much any other country or even Europe. So they're making all their profits from the US. I'm going to just let that sink in, and then move on to more onto the topic of antibiotics specifically. So additional challenges, other than them LMICs being completely outside the innovation space, they're going to have trouble accessing those new antibiotics because they on their own cannot pay for them. They have, regulatory bodies that complicate things. If you have a very small market where you're not really going to sell a lot of antibiotics, not a lot of people can afford it, but you have a very tedious antibiotic approval process, then what is the incentive for pharmaceutical companies to submit and to go through all of these hoops to get their new drug approved? And then their market entry for new antibiotics and diagnostics, as I said, is quite complex. So what do we really need? LMICs are not going to be able to do that on their own. We need public investment for development of new products, and potentially philanthropic and donor support to ensure access in LMICs, and not only to antibiotics, but also to those needed diagnostics. And we know that there is a precedent that worked very well, which is the rapid diagnostics for malaria, for which the uptake has been tremendous and has really changed the landscape for treatment. And then we need an urgent need for change in reimbursement mechanisms. So right now, pretty much every pharma company is incentivized by the volume of sales. But really, as you can imagine, this does not work for antibiotics. We need to steward those antibiotics and the new drugs so that we can keep using them. So we need a lot of things, but is there something happening? Well, there is. There are quite a bit to support antibiotic innovation. Is it enough? We don't know, but there is quite a bit. And this is actually a bill that's been introduced in 2021 to the US Congress by a representative from Colorado and one from Indiana. And it actually has a really neat name. And this is the Pioneering Antimicrobial Subscriptions to End Up-Urging Resistance Act of 2021, or in short, Pasteur Act, after Louis Pasteur. So kudos for the innovation and kudos for the really cool name. But the problem is it hasn't been funded, it hasn't been appropriated, and we are nowhere near seeing that come to fruition. It would be phenomenal for the antibiotic R&D space if it passes. But this is not the only thing that we're all hanging our hats on. Lots of other interventions, including many that are funded by the US government. So BARDA is a very big player, and BARDA not only funds on its own the earlier stages of development of antibiotics, but also indirectly funds CARB-X, which does the same thing, but has other global funders from Europe, Gates Foundation, Wellcome Trust, etc. JPAMR is another initiative that also supports research and development at different stages. And then that's one is funded by the EU mainly. AMR Action Fund is a private funding source. But the very interesting one is GARD-P, which is the Global Antibiotic Research and Development Partnership, which is a type of a public-private partnership where WHO plays a very strong role. And they have a unique place in this space because what they're trying to do is they're trying to develop antibiotics that are really only needed for problems that arise in LMICs and that pharma has no interest in researching, such as new antibiotics for neonatal sepsis, such as antibiotics for very drug-resistant gonorrhea, et cetera, et cetera. Challenges for innovation are very, very many. There's continued debate on how do we invest and what is the best incentive model, and it's strongly driven by pharma, and they like pull incentives, which means they like to be rewarded when their antibiotic makes it to market. They get a big chunk of money. That way they say, we're not motivated by sales. There are really cool new innovations, including a Netflix model, which exactly means like you subscribe to an antibiotic as a country, the same way you all subscribe to Netflix if you still do. Many early stage molecules are investigated, but really less than 8% end up making it to the market. And then there's a fragmentation of regulatory agencies, which really doesn't incentivize people to truly get their new antibiotic into smaller markets as well. New antibiotics are really not enough. How do we steward those? How do we get a good balance between access and excess? We have absence of qualified health workers in many parts of the world. We have lack of diagnostics and other interventions to improve outcomes. And the problem is when we do these qualitative interviews with various healthcare workers, physicians, prescribers, pharmacists, oftentimes they tell you, I have this very sick patient. I have so few resources. The only thing I can do is give them an antibiotic, and I have no idea what else I can do to save their life. And as you can imagine, as an individual health worker with that one patient, this is a very tough situation to tell them to be an antibiotic steward. So there are systemic issues in healthcare systems that also need to be addressed as well. And then knowledge translation to behavior change. There's a plethora of policy guidance when we're talking about stewardship. It's not like, oh, you want to steward antibiotics, you go ahead and figure it out on your own. Not really. I mean, the WHO came up with this, the blue document on the left, which is a how-to guide to develop antimicrobial stewardship programs for healthcare facilities, so hospital, in low and middle income countries. I contributed to that, but I also can tell you that the document is not perfect, and I'll tell you why. And then on the right-hand side is the equivalent that the CDC here developed as well for LMICs. I don't think it's an issue really with the guidance. It's always very hard to develop a guidance that works for 204 countries, territories around the world, because there are so many different specific contexts. The content is very valuable, it's very high level, and it needs significant adaptation to the local context. And often people think, well, it means that we really need to adapt this guidance to Lebanon as a country. Well, it doesn't work that way. I'll give the example of Lebanon, my home country. It's a very small country, so theoretically it must be easy, but it really isn't. There is even variability within one hospital or clinic system. Even in the United States, we have a 17 hospital healthcare system at Barnes Jewish, and we have critical access hospitals among those. Those are very different than the tertiary care academic center, where we have an ID physician and 3 pharmacists going around talking to people about how to use antibiotics better. We have the human factor and the available resources. Again, diagnostics. Who is paying for those diagnostics? Is the patient who can't afford their medicines expected to pay for those blood cultures or for that PCR panel? Are there local treatment guidelines that are relevant for that particular hospital and not so much the capital city hospital? Staffing ratios, knowledge and attitudes of healthcare workers, and then availability of basic resources that we touched on: water, alcohol, sterile supplies, et cetera, et cetera. So how do we even begin to tackle these challenges? It requires a lot of effort and a lot of resources to truly understand what does it take for these individual hospitals and healthcare systems within countries to be able to start their own stewardship programs and get to responsible use. We really need to talk to frontline health workers, because when you sit in Geneva or in Atlanta and you're developing this guidance, you really don't know what someone in a rural hospital that probably has wards with 10, 15 patients each in rural Uganda is really needing, or what they can and cannot do with what's available. And then talk to their hospital leadership and see, is this a priority? What are they going to do to support? And then get locally relevant quantitative data on diagnostics with cultures and sensitivities, baseline antibiotic consumption, and patient acuity. We often go to colleagues to partner with them in various parts of the world, and we're already assuming that they are horrendous at using antibiotics. And this is our premise when we started working with the University of Ghana a couple of years ago. Even during the COVID period, I can tell you that we looked at over 1,000 patient charts on antibiotics, and there were a handful who were on a carbapenem. If we look at that same number of patients, the same time period at Barnes-Jewish Hospital, it would be a handful times 100 people on a carbapenem. So assumptions really aren't really going to get us to the data and the interventions that we really need. They don't need an intervention to reduce carbapenem use in Ghana. All right, and now pop quiz. This is not an opinion. This is just a guess, and some people may know here, because I know you all have a really great kind of One Health programs and you work very closely with the vet colleagues. But what is the proportion of antibiotics used in animals versus humans in the United States? 2 to 1, so 2 times more antibiotics used in animals than in humans. 1 to 1, about the same. 3 to 1, so 3 times more in animals. Or 1 to 2, 2 times more antibiotics used in humans than in animals. All right, well, so the majority is correct. It is a 3 to 1. So 3 times more antibiotics are used in animals than in humans in the US. But a very big majority here knows that we use a lot more antibiotics in animals. So on the One Health front in 2020, and these are numbers from the FDA, 3 million kilograms of antibiotics were used in humans, and 11 million kilograms of antibiotics were used in animals. And as you can see, in humans, largest majority in outpatients for, unfortunately, often trivial causes. When we look globally on what's happening on the One Health front, these are circles that quantify the thousands of tons of antibiotics used in animals globally. And you can see where those big circles, the culprits are. The light red, which is what most of the circles are in 2020. And then there are some countries that have a darker circle around it. And this is the projection for 2030. So it's projected to increase in some parts of the world. China, Brazil, Mexico, big culprit. Australia, who usually does well in human health, big culprit. And that huge circle in the US, the worst offender, which state? Nebraska? No, not Nebraska. Missouri, unfortunately, and we are not proud of that at all. But this is a very difficult discussion. And while the international organizations are trying to come together, such as the Food and Agriculture and the World Organization of Animal Health, they're part of this group of 4 organizations, including the WHO and the UN Environment Program. They're trying to do that. But as you can imagine, there's a lot of dollars behind use of antibiotics for growth promotion and prevention of disease. And a lot of it will be lost if some countries stop using that. So the biggest challenger to the concept of reducing antibiotic use in animal health are Brazil, China, to a certain extent, the US, and a little bit in South Africa, probably because of the geopolitical alliances as well. We know very well that there's very clear linkage between resistance in animals and transmission in human through eating the meat, but also through transmission to farmers and people who handle the meat, et cetera, very clearly documented years ago. So it's really not news for anyone. Some more questions for you. And this is, about your own practice. And for the residents, what I'm going to ask you is, imagine today you're practicing without an attending. Nobody's going to question your choice. How long would you treat uncomplicated gram-negative bloodstream infection force with how many days of antibiotics? 7 days or less, 14 days, 10 days, 3 weeks, none of the above. All right. Okay. I hope that a big chunk of the 17 are residents. But this is great. I think still the majority would treat with 7 days or less. Very briefly, very briefly, on some landmark articles in Stewardship. This is a systematic review that was published actually last year, which looked at very many studies comparing 7 days or less versus greater than 7 days in outcome for uncomplicated bacteremia, gram-negative bacteremia, looking specifically at all-cause mortality, recurrence of infection, distant infection, more complications such as sepsis and septic shock, and 7 days or less was non-inferior to longer course of treatment. Evidently, all of these studies documented increased adverse events with longer courses of treatment from antibiotic use. This is an RCT, 7 versus 14 days, as you probably imagine, also found really no difference in key outcomes and an increase in adverse events with longer courses of treatment. The biggest challenge in antimicrobial resistance and beyond, I know many of us know that you really need 7 days to treat gram-negative bacteremias and not longer than that. But how often do we really apply it? When you see that one older, frail patient who's like, nope, this patient maybe needs a few more days of antibiotics. Or, well, the guidelines are telling me that I can treat for 3 days for uncomplicated cystitis, but this patient, she has a lot of symptoms. I'm just going to prolong it a little bit. We don't translate knowledge to behavior change. Knowledge on it by itself does not lead to behavior change. And we know that because we have all these awareness and educational campaigns globally that really don't work. We know their knowledge increases and they're more aware of the issue. Does it affect their prescribing practices? It does not. This is true for prescribers, for dispensers, so pharmacists, those over-the-counter sales folks, patients, farmers, and policymaker in AMR. So I talked a lot about the bad and the ugly, really a little bit about the good, as I promised earlier on. It was a very big overview because AMR is a multifaceted, really very complex problem that needs multiple different interventions. But the thing that I hope that you will leave here with is that AMR is really a US and a global problem. We learned from the COVID pandemic. It's true for all infections. Really, there are no borders. There are no passport controls for infections and bacteria. If it is a problem in Southeast Asia, it's going to be a problem for us. And it is already a documented problem here in the US. The solutions are multifaceted. They require additional investment and commitments in low and middle income countries. How does that directly affect you? You're just gonna say, well, I care about my patient here in Madison. True, but the US government has some initiatives in the pipelines that you can think of supporting as a citizen and as a concerned healthcare provider. Global guidance needs local adaptation, and this is very true that I hope particularly the global health colleagues here, the faculty, I know 100% know that their work is already phenomenal here, but for our trainees, just don't think that the global guidance is one that you're going to be able to apply everywhere without doing local adaptation. And we really need additional research to understand what's going to enact behavior change in various stakeholders. So with that, I am going to conclude and ask you all for any questions you may have for me.
Great. So we have a couple of minutes actually for questions, and we'll start by questions from here, if there is any. And while we are waiting for a question to come in, one of the biggest challenges that we see in developing country is diagnostics. For example, if you see in Africa, C. diff, I mean, the data is not complete. Besides South Africa, I don't know even any country who systematically do C. diff work diagnostics. And the same thing for blood cultures also. We were doing a neonatal sepsis study in Ethiopia, and the bottles that they used for blood culture was actually locally manufactured, and their positivity rate was like 10–15%. And we brought our own bottles, and it went to 60% or 65%. It's going to be published soon. So, and the problem is the blood culture bottles are, 2 sets of blood culture bottles probably are a salary of one decent employee there in the hospital, even for a month. So how can we convince decision makers in developed country actually to invest in diagnostics in developing country? Because at the end of the day, the resistance that we see there eventually is going to creep up here. I mean, it's a very loaded question, but that is really the crux of a problem in antimicrobial resistance.
Oh, I have mine. I know why I reached for that mic. So this is a really great and somewhat question that takes us also a little bit to the higher level. So what is it that convinces policymakers to do anything, particularly in low and middle income countries? Oftentimes it's something that has a lot of political push on the global level, and there's money coming behind it. AMR was the star of the global health scene a few years back, and then the pandemic kind of took that spotlight from AMR. So if there is outside money coming, if there is a mandate somehow by a global organization, and those are very difficult and tedious, but what we really need for AMR is we're still relying on some of the techniques for diagnostics that are actually decades old. And we know that we can do better with molecular diagnostics. And ideally, if we get to molecular diagnostics, those eventually can end up being relatively fast to use, relatively cheap, and a lot more available to many parts of LMICs. It will require initial support that probably has to come from donor and philanthropic funding, and then eventually for it to become a sustainable program. And we've seen that succeed quite a bit, as I mentioned, with the malaria rapid diagnostics. So why can't we think of something like that for AMR? And it's not a far-fetched issue. There's a lot of money being put into developing new rapid molecular diagnostics for bacterial resistance as well. So I think there are some promising diagnostics in the pipeline. So hopefully pretty soon we're going to see something like that coming up.
There's one question from... Very interesting question. Can you comment a little more on the reliability of surveillance data for antimicrobial resistance in low resource settings and collective effort to improve that data?
Yes, absolutely. So I alluded to that a little bit. The surveillance data is actually reasonable, but it doesn't reflect the full spectrum of true resistance. As I mentioned, that resistance data is coming from reference centers, often in the capital cities and in big universities. And this is what's being collected, because the way WHO is asking countries to report, they have to report on a specific set of drugs and a specific set of resistance. And when you only have it from the centers that perform these, then that's what you're going to report. So we know this is not reflective of what's in the country. There are some external efforts. So the Fleming Fund from the UK has put a lot of money into these surveillance programs, and the US CDC, with a select number of countries globally, is trying to build its own global surveillance network to supplement that of WHO. So there are efforts to do that. Is it happening in every single country around the world? It's not. The US CDC chooses the countries based on, we're going to say, geographic location, but I think we all know that it goes a little bit deeper than that. But there are, the Fleming Fund has mostly funded former countries from the Commonwealth. So there are countries that are left behind. So we do need more investments in the surveillance infrastructure that is not necessarily tied to politics or history or anything of the sort. So.
At the end of the day, you don't get what you didn't collect. Again, in Ethiopia, very few hospitals who can do actual blood culture. So the data for the whole country of 120 million people comes from those few hospitals. So that's what it is. Rob?
Great talk. I know almost nothing about it, but it's much easier to talk about other industries' problems than our own. You know, I recently read that the Netherlands apparently is like an agricultural powerhouse, so much so that they produce so much meat, so much cheese, so much agricultural products that they export, that like that is their biggest source of CO2. Right? And so the government's trying to crack down on that, but they didn't seem to be really bad in terms of agricultural use of antibiotics. So is there a way that we can sort of highlight which countries, which regions actually do a good job of producing necessary food without actually blowing through antibiotics?
Absolutely. And the Netherlands is the perfect example. They were one of the earlier countries globally to completely kind of stop using antibiotics for growth promotion and prevention. And that was decades ago. Denmark is another country that also produces specifically a lot of pork. There's a big pork industry. There's a lot of cattle industry as well, and dairy, but they use zero antibiotics for those purposes. So they're doing great. Absolutely. But one thing to consider is that this is the Netherlands and Denmark, very highly resourced countries and very highly resourced settings that also have the science and the technology and the subsidies from the government if needed. So a Danish farmer or a Dutch farmer, they're never going to starve at the end of the month if something happens to their cows or swine, etc. So it's a very delicate balance. And then we have the countries that produce in masses for their own population, but also for exports. So Brazil, China, Argentina, etc., who are really not kind of falling in line with that, because their bottom line will be significantly affected if they need to do what Denmark and the Netherlands have done, which is these, kind of much larger farms where animals are free to roam, where their feeds are actually very well thought of, etc. So it is also a big kind of economic discussion of how do we get mass producers to do what smaller countries, even if they produce a lot, have been able to do. There is a lot of resistance for outside interventions in many of those countries, for sovereignty issues, of course, but also because nobody wants to really look at what's happening in these farming spaces.
We have 1 minute and there's one question. Thanks for reviewing this important issue. Any thoughts on why the regional difference, especially in some parts of US South, in increased antibiotic prescribing?
That's a really, really great question. There are lots of different reasons that we think are happening. If you look at the better states, particularly out west and also some in the northern part of the Midwest, we do believe is that there is a lot more awareness of the issue. But also one thing to know is that, and that's really absolutely not pointing fingers, but telling us what we're lacking as far as education and training of our healthcare providers. There's a significant difference in the number of prescriptions by category of healthcare providers. And I'm not going to call them the biggest offenders, but the category of healthcare providers that prescribes the most antibiotics are our nurse practitioner colleagues and our physician assistants. And that really goes to looking at the education of antibiotic prescribing that they receive, followed by, primary care doctors, followed by dermatologists actually. But this is a bit, well, but this is tricky, right? Because we're also counting doxycycline and minocyclines that are used long-term for their anti-inflammatory properties. So this is, I would take the dermatologist category with a grain of salt, followed by primary care doctors and emergency medicine doctors that we often kind of point fingers at, but they're actually not doing so bad. So there is also the density of physicians, the density of specialists. We know pediatricians do very, very well at being stewards of antibiotics. So in many parts of the South, it's also a different mix of healthcare providers and prescribers as well that is likely also kind of contributing to some of those differences, especially in outpatient prescriptions.
With that, we'll conclude. Time is up. Caline will begin for a couple of minutes after the round. Thank you.